So I want to thank you so much for being here with us today to talk about trauma-informed care and the relationship between trauma-informed care and health disparities, and the Veterans Health Administration as really, in our view, the only system in the United States that takes trauma-informed care seriously, does trauma-informed care, and also seriously and systematically addresses healthcare disparities. That may be news for some folks who have heard not anything very good about the VA, and I would argue, as an expert on VA care, and having worked for years with veterans and observing VA care, and also as a senior policy analyst and co-founder of the Veterans Healthcare Policy Institute, we would argue that the attempt to denigrate the care at the VA exists precisely because it is so good, and because a lot of ideologues on the hard right who are anti-government really don't want a system that works and works well and addresses some of the most vexing problems in America and society and American healthcare. They really don't want that system to exist. And so we're here to talk to you about the VA. We're here to talk to you about the importance and the impact of trauma on healthcare and on health disparities. And I'm really excited to be sharing this session with my dear friend and colleague, Eddie Machtinger, who will introduce himself. Eddie, do you want to introduce yourself? Why don't you introduce yourself now to folks?
Hi, everyone. Hi, Suzanne. My name is Eddie Machtinger. I'm a primary care physician and professor of medicine at the University of California, San Francisco. I direct our women's HIV program. I direct our Center to Advance Trauma-Informed Healthcare, and I co-direct a large state initiative focused on trauma called ACEs Aware. I'm also a board member of the Veterans Healthcare Policy Institute, and I'm really impressed by the VA, and I'm here because of that and because of Suzanne.
So I want to start to talk to you a little bit about the Veterans Health Administration. So what people know about the VA, which is the Department of Veterans Affairs, which is the second largest federal agency after the Department of Defense. The Veterans Healthcare Health Administration is the largest publicly funded. It's the largest healthcare system in America. It's the only publicly funded national system in America, and it serves not all veterans, sadly, but a very large amount of veterans, and it also serves all Americans through its teaching of healthcare professionals, its research mandate, and its fourth mission to act as the backup to the rest of the American healthcare, what I would call non-system, in times of national, local, and regional emergencies. And I think that the VA serves us all, as for those of us who want a functioning healthcare system. It serves as a model of care and has developed models of care. I'll talk a little bit about those after Eddie talks, but I just do want to introduce the VA as a model of a system that takes trauma very seriously, and that also takes efforts to reduce healthcare disparities very seriously. The VA patient population, as veterans, whether they served in combat or not, experiences a lot of trauma. Being in the military is a pretty traumatic experience, whether you're in combat or not. About 30% of veterans have some form of PTSD, whether it's combat or not. 1 in 4 women veterans have suffered military sexual trauma, everything from harassment to rape and sometimes murder, of course. Then they've stopped suffering, but there's a horrible incidence of military sexual trauma in the military. And it's not just women who suffer from it, but men as well, but a much greater percentage of women, because the military is extremely misogynist and has not dealt with these problems very seriously. Mental health conditions are rife in the military. Probably over 50% of veterans have some kind of mental health condition. And many of them suffer from chronic pain and other kinds of conditions that both exacerbate mental health conditions and create them. And it's kind of an intertwining. You can't really disentangle these problems. There's a very high rate of suicide among veterans, a higher rate than in the same age groups in the American population. And so these very traumatic conditions, the VA over many, many decades has been forced to deal with them, deals with them very well, in my view, in our view, and in the view of many, many studies. And you can see this in outcomes, study outcomes. I will put in the chat a place on our website, the Veterans Healthcare Policy Institute, where you can look up the studies that show outcomes of VA care. And I would also argue that the VA has the only functioning system of mental health care in this country. I mean, we know that the mental health care system in this country is a disaster. 55% of American counties, all of them rural, have no psychiatrist, psychologist, or social worker. The VA sometimes are the only mental health providers in those areas, and the VA's telehealth capacity can reach into those areas. There have been many studies of the way the VA deals with health disparities. Let me just read. In 2014, the American Public Health Association devoted an entire journal about the issue of an entire journal about the VA's efforts to deal with health inequities. And it noted that the VA endeavors to be a leader in health inequity, and it detailed the issue, detailed the ways in which the VA was trying to initiate projects and programs designed to identify and analyze and reduce the causes of health care disparities that negatively impact African American, Native American, LGBTQ veterans, among others. In one study, for example, there was a study that appeared in the journal Circulation, and it showed that Black veterans with kidney disease and cardiovascular disease had a lower incidence of mortality and incidence of coronary heart disease and stroke than white people, because they had access to healthcare through the VA. And during the COVID epidemic, we saw that because of the VA's extraordinary efforts to bring people in to deal with COVID, that people of color didn't die in high rates, disproportionately high rates, as they did in private sector healthcare. So it's really important, I think, for folks who are interested in healthcare reform and who take it seriously to look at the VA and the models and the efforts that it has made in these areas. And before I talk a little bit more about those efforts, I really want to have Eddie, who's an expert in trauma and health disparities, talk about first the impact that trauma has on health, and then the ways in which a healthcare system and the people who work in it at all different levels can reduce and mitigate and interrupt the impact of trauma. So we're going to have a kind of a conversation, and I'm going to start by first asking Eddie to talk about how he became interested in the impact of trauma. I mean, how did you, in a way, discover the fact that it was traumatic experience, not just diseases, that impacted the well-being and even the lives and deaths of your patients?
Yeah, thanks for that question. So I'm an HIV doctor, and I take care of a large group of women um, living with HIV, most of whom are Black and brown, because that is the population that's most affected by HIV, but really all types of women in our clinic. And early in the epidemic, there were no drugs to treat HIV up until 1996. So HIV started in 1981, and all the way for 15 years, there was no drugs to treat it. And basically, everybody died from HIV over the course of, if they weren't treated, over the course of about a decade of having it. And so that's how we experienced, life and death in our clinic until 1996, when we got effective antiretroviral medications, effective treatment for HIV that really makes it a completely controllable, treatable condition that isn't even contagious once you're on the meds. But what happened in our clinic after 1996, when people started the HIV medications, was they kept dying. And they kept dying at really, really high rates, but they stopped dying from HIV because that was controlled. But they kept dying from depression and suicide, from substance use and overdose, from lung disease, from heart disease, from strokes, from diabetes and obesity, at rates that were really, really high. They were dying very young from really preventable illnesses that weren't related to HIV. And it really begged the question to us was, what was going on? And when we took a step back and thought about it and looked at our population, we realized that the common denominator throughout our patient population was trauma, was lifelong histories of trauma that in most of them started as kids. And that trauma as a child predisposed them to many different problems. Trauma as a child has a physiological impact on the developing brain and body. And it has a predisposing impact across the lifespan to many, many, many adult physical and mental illnesses. And so that trauma as a child is what predisposed them to being in situations that were high risk for HIV. But that trauma as a child and then ongoing trauma as an adult predisposed them to all these other conditions: mental illness, substance use, early heart disease, early stroke, early kidney disease, obesity, diabetes, that were killing them and we're killing them at such high levels in our patient population. And these were women that I loved and knew for really long periods of time. And so we decided that we really needed to reframe our understanding of what was hurting our patients and what we needed to address as trauma. And that became the lens by which we saw our patients and became a whole new focus of my research and my career, and the inspiration for our new center, and how we have now designed our system of care for the patients we care for in our clinic.
And so how does the way you design your clinic now compare to how you had designed it before? What have you done differently? I mean, I know you pretty well. You're a very relational guy. Your staff is relational. I mean, how does, it's just being a good person. It's obviously more than just being, quote, caring and so forth. You've done very deliberate things to change the way your clinic is designed and functions. And can you talk a little bit about the kind of before and after?
Well, yeah, I mean, I think we named the problem. And naming something in medicine is really crucial, because then if you name something, you could develop a way of understanding it and treating it. Whereas if you don't name it, people are mysteries. Like, I mean, even just basic stuff, like, why is this person yelling at me? Why is this person, so dissociative, so weird? Why is this person not taking the medicines I'm prescribing? why does this person have trouble controlling their eating even though they're getting their toes amputated from diabetes? Why is this person continuing to smoke despite having lung disease? Why are they addicted to crystal meth? Why are they depressed? I think, if you ask medical students and other doctors, like, what are the origins of these problems? They give you the craziest answers. They think it's genetic. None of this is genetic. None of it is genetic. You ask them what their role is in treating those conditions, and they give you the funniest answers. They're there to give people medicines, or they're there to help people. But I think if you understand that so much of this illness and trauma, so much of this illness and behavior, difficult behavior, self-destructive behavior, adversarial behavior, is due to trauma, it has a massive impact on everything. And just in the most affectual sort of way, you're just, as a provider, so much more understanding and compassionate and patient. And so if the person is kind of reactive and kind of acting out or not taking medicines or doing things that are self-destructive, if you understand that that's a consequence of trauma and PTSD, you just don't take it personally. You don't judge them. You actually love them more, instead of, literally, the women in our clinic who have mental illness and substance use, and I think so many veterans who struggle with so many of these stigmatizing problems, they have a very reasonable expectation that their provider will dislike them, will punish them, will hate them because they are using substances or mentally ill or not abiding by their instructions. And I think by understanding the origin of their illness and trauma and PTSD, internally as a clinician, they make sense to you. You've demystified them, and you can engage them from a place of calm, understanding, compassion, and love that really is the basis for being able to effectively care for people. Because the people who are most at risk for bad preventable illness and death usually have stigmatized health conditions. Stuff like violence in their lives, intimate partner violence, substance use, depression, mental illness of all kinds. And if they go into a clinic, they have a really good spidey sense for whether someone likes them or not. If you're a Black person in this country or a brown person in this country, you know where you're liked and safe, and you know where you're not liked and safe. So by understanding trauma and PTSD and developing kind of a compassionate and patient understanding and approach to these people who are most in need of services, most at risk, can feel like they can reveal themselves and trust you enough to reveal themselves. And it's only if they reveal themselves and reveal what's going on in their lives do you have any chance of being able to treat these conditions. So I guess what I'm saying is, fundamentally, the first step is just understanding the origin of so much illness and difficult and self-destructive behavior and death. And from there comes a whole downstream systems change in the way you practice and the way you act and the way you feel, and then in the treatments you deliver. Because if you know that someone's depression has significant childhood trauma as a source of it, which most do, then you are going to not simply give them an antidepressant, but you're going to refer them to a therapist who understands childhood trauma, which people at the VA do. If you know that their lung disease and their heart disease is related to trauma, their ongoing trauma and their inability and not being afforded opportunities to cope with prior trauma is going to make treating their heart disease not nearly as effective. So you will address their intimate partner violence. You will address their history of childhood sexual abuse as part of the treatment for their cardiovascular disease. And you do that in relatively simple ways. You do that by talking about that with patients. You do that by not being reactive to patients and allowing them to have like a good connection with you that is calming to them. And then you do that if they want by referring them to very specific trauma therapies that good trauma therapists know how to do, along with the treatment of their physical and mental conditions. So it's a snowballing effect. Once you understand it in medicine, once you name something and understand it, it changes your treatment algorithms for that thing. And I think in medicine right now, most people do not understand the link between trauma and most causes of preventable illness and death and all causes of health disparities outside of the VA. The VA is organized around that principle.
So can you talk a little bit about, so what you're describing as the role of primary care and healthcare professionals and staff, because it's not just the doctor or the nurse practitioner or the social worker, it's how the clerk deals with you. I remember I had a serious side effect of a surgery and had a very serious and upsetting complication, and I was really a wreck for a long time. And I would go to this one specialist office, and the first person that you'd sort of hit was this clerk who really oozed a kind of green slime of hostility. And it made you kind of almost not want to go into the office, right? Or I would be trying to I would try to be nice to her, so she would be nice to me. And I remember saying something to one of the fellows in the office, and they said, "Oh yes, people have been complaining about her for years." And I'm like, well, she has an impact on you, And I think people who don't understand trauma or the impact that people can have on, and illness can traumatize you without having had, I think, early childhood experiences of trauma, which I definitely had. But I think that there was just a sense that, oh, well, she was kind of unpleasant, and yes, people could get over it, but I don't think people had any clue that you might not want to make an appointment, you might not want to come, this impacted your view. So it wasn't, and I think probably in that office they thought, well, the doctor is really the only one who counts, so she's not oozing hostility, so that's all right if the secretary oozes hostility. And I think you're right about the lack of understanding of the impact of people's behavior. Or I don't know, maybe it was like, oh well, you're an adult, you can kind of get over it and slough it off and whatever. But I really wanted to ask you to describe to people that when primary care or when healthcare is organized around a recognition to trauma, that you have talked to me about a concept that I think is very important for folks to understand, because it really bears on health inequities and disparities, which is this idea that protective factors can interrupt experiences of trauma and help people recover from them, and maybe even prevent future experience of trauma. And I think this is not a concept that is familiar to folks. I think many people think, oh, well, people had bad traumatic experiences, childhood or adulthood. There's really not much we can do for them except to send them to a therapist or give them an antidepressant or an anti-anxiety drug, or I don't know, be nice to them on occasion, whatever. But I think this concept of protective factors is very illuminating to me. And I think it would be useful to talk about to the audience about how primary care and healthcare can serve as a protective factor in the patient's journey of trauma.
Yeah, I think maybe the best way to explain that is through just describing some of the research that links trauma to health. And I'll explain why. So if you look at broad population studies, like studies of the general population, and you look just at very significant trauma as a child, they call that adverse childhood experiences, ACEs. And ACEs have been really studied as of late because the impact of trauma on developing brains and bodies, the physiological impact of trauma as a child has a really destructive impact on that brain and body's development. And so the most research has been looking at these ACEs, adverse childhood experiences, and people who have had 4 or more categories of these adverse childhood. Well, let me put it this way. The best data shows that when you look at adult illnesses like depression, common adult illnesses, there's a way of looking at how much of that illness came just from childhood trauma. And the CDC just released these statistics. 44% of depression in adults is just due to these 10 categories of childhood trauma. 33% of adult smoking, 27% of lung disease, 24% of heavy drinking, 24% of asthma. Like a huge component of adult illness is directly because of experiences of these 10 categories of trauma. And those 10 categories of trauma don't even include many forms of adversity as a kid. It doesn't include discrimination, being in foster care, living in violent neighborhoods, the death of your parent. It doesn't include, all historical trauma like genocide or slavery. And then it doesn't include adult trauma. It doesn't include all the trauma that people have during war and as adults, interpersonal traumas, sexual abuse, any of that. And so what that speaks to on a population level is the majority of mental illness, and probably the majority or a large part of most common illnesses, is due to experiences of childhood and adult trauma. Doctors don't even know that. I mean, it's just basically, it's a crazy thing that is not better understood in healthcare and in medical school. But in terms of protective factors, you can look at a person on an individual level and see that trauma is not deterministic of poor health. So you can have one kid who has really bad trauma as a kid. They may have undocumented, non-English speaking parents. They may have lost one of their 2 parents to incarceration or deportation. They may both have had sexual abuse as a kid, serious childhood traumas. And you look at one kid, 2 kids, identical experiences of trauma. One kid goes on in adulthood to having depression, obesity, substance use, homelessness, and abusive relationships, really not doing well. And you look at the other kid who had the exact same childhood trauma, who is healthy, married, has 3 kids, and employed, and seems like a pretty happy person. And so what is the difference? What happened with the same amount of trauma, but 2 totally different life courses? And what happened was that the kid who had the life course that was more healthy had what we call protective factors. Protective factors are really common and intuitive. They're, in general, nurturing, supportive relationships, usually as a kid with an adult who can see you, who you trust, and who's there for you. And then safe, supportive environments to live, learn, and play. Those are the most common protective factors. There's other protective factors like access to meaningful engagement with others and with connectedness to something that really matters to you, like church or sports or other things like that, and then opportunities to figure out how to have cognitive and behavioral regulation that comes through various therapies or through good relationships with adults. But these are these protective factors, basically safe, stable, nurturing people and places to live. If you have those have physiologically positive protective impacts on your brain and body. So positive experiences have a physiological impact. Traumatic experiences have a physiological impact. And so if you have somebody who has trauma without the protective experiences, the physiological impact of that trauma leads to all of this preventable illness, death, and health disparities. If you have someone who has trauma and you have the protective factors, those protective factors mitigate the physiological impacts of that trauma on later health and illness. So trauma is no longer deterministic at an individual level. And so protective factors, why I think that's so powerful is that I want to be a protective factor for my patients. Like, what is my role as a clinician, as a physician in the lives of my patients? Ask that to medical students. Ask that to doctors. Who are they? What do they do? What's their role? And very few of them will say, well, my role is to be a protective factor that can act as a buffer of all the trauma they're currently experiencing and as a way of helping them heal from all the trauma that they have experienced. And it doesn't, like my friend Alicia Lieberman, who's a world famous trauma therapist, says, you don't have to be a therapist to be therapeutic. And so how does that happen? And so the same protective factors that help protect kids, the presence of a supportive, loving adult who sees you and supports you, and a safe environment in which to live, learn, and play, applies in my clinic. So every aspect of care in our clinic is designed to be loving and comforting. And I don't mean like teddy bears and fish tanks and like baby blue colors on the wall. I mean interpersonally. Like the person who greets you in our clinic doesn't yell at you for being late and doesn't blame you for being late and punish you for being late, which is actually what happens in most healthcare. You come late and they like are angry at you. And like in our clinic, if you're late, the whole point, and and then someone's kind of amped up about it, our mama bear person who is at the front desk walks around the front desk and ideally gives the person a hug and says, listen, I'm so sorry you're late. I'm sure that there's like all these terrible, difficult things that made it hard for you to get to this completely inconvenient medical center in which we're working. And they then work with that patient to help them with their most immediate needs. And they'll say, hey, listen, let me try. I know you can't see your doctor anymore because you came late, but whoa, we have all these other services. Here's an apple, here's some little, cheese fish, these little snacks we have. And let's talk to your social worker, or let's talk to your therapist, or let's get a bunch of shit done, even though you can't see the doctor. And and when people see me, what's my main intention with every single one of my patients is to say something nice. Literally, like one thing I can do. So I'd say it's not like I'm lying. I just try to find something nice to say. So I'll say, like, that's an awesome backpack. Where in the world did you get that backpack? And I do that because I mean it and I love my patients, but I also do that because these positive experiences matter. They matter physiologically to people. And they matter to develop trust and connection so that a patient can feel safe enough and comfortable enough with me to tell me the stuff that matters so I can help them.
It's funny that you mentioned, it's not so funny, but I had a recent experience. I mean, I think very often medicine, the way it's currently practiced, can actually be not just not just can it be not address trauma, but can actually be traumatizing, right? And I had an experience about a month and a half ago where I went to my primary care provider and I was having a very serious shoulder injury that really freaked me out and I was in a lot of pain. And I was 10 minutes late.
Bad Suzanne.
Exactly.
Bad patient.
And the woman at the front desk was I think she had adapted to become this hard shell because of all the punitive rules that they impose on patients. And so I was literally 10 minutes late, and it said on the board that the doctor was going to be 30 minutes late, and they would not see me. And I was like sent home, and her affect was just this, bad patient, no understanding. Nobody had, by the way, ever told me that if I was 10 minutes late, I wouldn't be seen. And it was
what's interesting about that, where I'm talking about like demystifying the behavior and the illness of patients. It's not a mystery why that person acted that way. Our care system is really fucked up. I mean, it's almost like I don't even want to go into how screwed up our primary care health system is. Like it's so screwed up. And one of the ways in which, so the primary care clinics, general primary care clinics, are really understaffed, both with clinicians and interdisciplinary teams. Like they're just massively understaffed because people don't want to go into primary care. It's underfunded, meaning that the clinics don't have enough personnel, and the pay is less than most of the other fields of medicine. And it's just overwhelming for the people who work in primary care clinics. It is, the clinics themselves are traumatized by the system. And they act like traumatized people. They have the same symptoms as traumatized people. They're hierarchical, they're reactive, they're fragmented, they're disassociative, and they're traumatizing not only to the people who come, because people feel this. People have experienced trauma, or people have experienced all forms of trauma. They feel this when they come in, but they're also traumatizing to the people who work in them. So you get people who go into this for very good reasons. Most people go into primary care in all the different aspects of it for good reasons. They're good people, but they're traumatized people by the system, and the system acts in a very traumatizing way. You know, traumatized people are traumatizing. Traumatized clinics are traumatizing. Right. And then the one example from my own health system is, I work at UCSF, a major national medical center. We have all this advocacy. We have educational tracks here. We have whole research endeavors about disparities and about how, we really need to overcome disparities, and all this research about how to do that, and all these educational pathways for students about how do you take care of, people from marginalized backgrounds. But our primary care clinic at UCSF Health has been closed to all new patients for 2.5 years because there was a mass exodus of primary care providers. So there is a crisis within UCSF's primary care clinic such that it's closed during COVID to all new patients because the clinic was just, 5 primary care people left all at once. It was just not a good place to work. As an example of that, for 28,000 patients at the UCSF Health primary care clinic, main primary care clinic, there's one social worker. So you think of interdisciplinary teams, of people. Like in my clinic, I tend to see the patients who are most complex with a social worker, or with a pharmacist, or with a pharmacist and a social worker, because otherwise I can get overwhelmed, and they can get overwhelmed, meaning the patient. And so if you have 28,000 patients and one social worker, what does that mean? It basically means that you're saying, don't come here if you have any complex health and social needs. In other words, don't come here if you're at risk of having health disparities. We don't want to know about your intimate partner violence. We don't want to know about your difficulty with housing. We don't want to know about your childhood sexual abuse. Stay away from here because we don't have the resources to deal with that. And that's how a lot of these new primary care systems are designed. Like One Medical, which was just bought by Amazon, you have to do all of your appointments for One Medical on an app. So if you don't really know how to navigate apps, you can't go to One Medical.
You just,
so
Eddie, I don't know.
Oh, did I just freeze for a second? So
No, that's
all of that's to say that the VA, as a single payer holistic healthcare system, is one of the few functioning healthcare systems in our country. The outcomes of care at the VA are clearly better than outside the VA. You look at primary care health outcomes for the key conditions that are measured in primary care, and you get better outcomes of care if you're seen at the VA than if you're seen at non-VA medical centers. If you look at the VA, you have better preventative care across every category. There's 12 categories that they typically measure. Every category is better in preventative care at the VA compared to non-VA medical centers. The access to care at the VA, they'll see you. access for mental illness. We have a joke, this isn't a joke, that our patients, if they go into any other primary care clinic, they'll call the police.
Yeah.
Because we actually welcome people with real mental illness and substance use. And it's not a joke. They go other places and they call the police because they're considered impolite or dangerous. When they're not dangerous, they're just needing care. And so our systems of care in this country are really, really broken. And why am I invested in the VA and wanting to be on this call is because the VA is a model, it's a beacon of a functioning system of primary care and healthcare in general, especially for people who've experienced trauma. And let me just say one thing about health disparities. So a lot of people talk about health disparities. And health disparities basically are, disparities in health outcomes across races. And there's really, really dramatic health disparities in this country. I mean, it's just super dramatic. So like Black women are 3 to 4 times more likely to die in childbirth than white women. Black babies are twice as likely to die in childbirth than white babies. Black adults are 50% more likely to die from heart disease prematurely or stroke prematurely. Latino children have the highest rates of obesity. American Indians have the highest rates of suicide and smoking. 70% of new diagnoses of HIV are in Black or brown people. 50% of Black gay men are estimated to that they will become HIV infected in their lifetime. Half of Black transgender women are already infected with HIV. These are just examples of amazingly dramatic health disparities. Early death, early illness in Black, Latino, gay, transgender, Native populations. None of these things are genetic. Let's just put that out there. None of the health disparities that are driving these premature deaths are from genetics. They're all from the lived experiences of Black, brown, Latino, Native, gay, and transgender people in this country. And what is that lived experience that drives all this illness? It's experiences of trauma in the absence of sufficient protective factors.
Right.
That's where health disparities come from. An imbalance of too much trauma, too few protective factors equals premature illness and death. And what is the health system response to that? The health system response is, okay, you're right. We can't relive people's childhood. We can't get rid of discrimination. We can't get rid of community violence. We can't undo a lot of the traumatic experiences that people have had and continue to have. But we as a health system can act as a protective factor, both through our relationships with patients, through the care we deliver, and by conjuring other protective factors for them that they need in their lives. Referrals to mental health, referrals to substance use, and then access to legal services, housing services, financial services that serve as protective factors unto themselves. And that's the scope, that should be the scope of medicine, but it isn't in outside the VA at least.
So I think this is a good place to sort of transition to show folks a little bit about how the VA provides these kind of protective factors. And I think that, one of the things that, there's so many ways, because the VA is a healthcare system. It's not a medical care system. They obviously, the VA deals with veterans' physical and mental conditions, but the VA, deals with homelessness. The VA I wrote about all this in a book called Wounds of War, how the VA delivers health, healing, and hope to the nation's veterans. I regret that subtitle, Eddie, a lot because I think it's very accurate, but tragically, I think it reinforces the notion that the VA only serves veterans, and a lot of folks don't really care that much about veterans, even though we give lip services to thank you for your service. And I wish I had subtitled it, how the VA can be a model for all American healthcare. But, the VA has transportation. I mean, you go to the San Francisco Bay Area, and I live in the Bay Area, and there are buses that take folks from Eureka and Ukiah and Santa Rosa to the medical center. There's a place for people to stay if they need care and they need to stay overnight. There are homeless programs. They work with the Department of Housing and Urban Development to address veteran homelessness. I spent a month with a VA social worker going around San Francisco, looking at alleyways and at Union Square and going up to people who were homeless, and like she was trying to find vets. I mean, I don't think UCSF sends folks out to scour the streets of San Francisco, for homeless patients. Like, oh, you could come to us, and
But no one can come to UCSF for primary care.
Right. So yeah, right. So it doesn't matter how rich or poor you are, but I mean, they have a veterans legal outreach program that helps veterans with legal problems. They have vocational rehabilitation. So for example, if you have PTSD, I got to know a vet in Honolulu who had PTSD from traumatic experiences in Iraq, and he was a sheriff, and he had been in 2 residential treatment programs, and basically a psychiatrist said, look, if you continue being a sheriff, where you're kind of in this very violent milieu, you're going to keep on having PTSD, you're going to keep on being triggered, and you're going to lose your family, which he really didn't want to do. And they trained him to be a construction worker. I think actually it was a blacksmith. And I mean, it's really astonishing, the range of issues. I mean, there's a program in San Diego, which is a residential program to prevent homelessness in Iraq and Afghanistan veterans, and they teach them salsa dancing. Now this is in a healthcare system, right? They're teaching you salsa dancing.
Well, I'm just going to state the obvious, but I'll just say it. There's a reason why none of those things are happening at UCSF Health or in most major medical centers. It's because it doesn't make them money.
Right.
And so I'm not kidding. Like the institution, even public institutions, are designed to make money. And it's not like, oh, we're in a profit, of course we have to make profit. It's like 100% designed to make money.
Right.
And so an example would be, I have been to my own ER at multiple times over the course of my life with my husband, Willie, who has a propensity to get into bike accidents. And so every few years we end up in the emergency room because he got in another bike accident. And the first time he went to the emergency room, he got asked for graham crackers, and he got honey-made graham crackers. And honey-made graham crackers are fairly top-shelf good graham crackers. And I like graham crackers, so I really appreciated that and ate a lot of honey-made graham crackers. A couple of years later, we went to the emergency room and we asked for graham crackers, and we got a new type of graham cracker, and they were Keebler graham crackers. And Keebler graham crackers are clearly middle shelf graham crackers. And I was like, shoot, they've changed the brand of the graham crackers. These are pretty bad. I recently went to the ER again with him, asked for graham crackers, and they gave us Monarch brand graham crackers. Now, Monarch is not even a shelf brand of graham cracker. It doesn't exist in the general population. It's the cheapest form of graham cracker you could possibly buy. And I'm saying that not as a joke. I'm saying that we have a lean movement here. They call it lean. Every single cost-saving thing possible, down to the penny, is done. Every valet person is outsourced to an agency. Every custodial person is outsourced to a different agency. Every security person is outsourced to an agency. Every graham cracker is sourced from the lowest, cheapest possible vendor. So do we really think that they're going to be magnanimous when it comes to welcoming people who don't make them money? They're not. So people with complex health and social conditions, it is designed to not see them in every possible way. The single social worker in the Department of General Internal Medicine at UCSF Health is designed to preclude people, meaning only having one, with complex health and social conditions from being seen at UCSF because they lose the institution money. So God forbid you have complex health and social conditions you need to be seen in a typical American health system, even a public one, like the one in which I work at UC. And that's, the origin of the differences between the VA system and almost all of the rest of healthcare is they're not trying to make money on every single thing they do. They're trying actually to take care of the people that are patients in their institution.
Right, and I think that not having a fee-for-service, I mean, all VA providers and staff are on salary, not fee-for-service, and not having a fee-for-service system and not having the mission as a profit-driven mission allows you to embrace a different view of your patient and of your mission as a clinician, as a staff member. And I think that because I think there's a part of this problem that is money driven, but a part of it is also a kind of idea of what medicine is and a very narrow medicalization of everything. And I think that what trauma and informed care allows you to do is to sort of demedicalize and relationize healthcare and the services and your approach and attitude to the patient. Because I think even, the danger of I mean, if we waved a magic wand, you and I, and wouldn't that be wonderful, and we suddenly had profit disappear from the healthcare system, you would still have people who have a very particular view of what their role is. You would still have people who were educated to view their role as diagnosing and treating illnesses and, offloading the relational part to the nurse or, or to the psychologist or the psychiatrist, right? And I think that and also I think in medicine, we select people who are good at taking tests, right? And not necessarily good at relating to people. I mean, I think there's multiple factors, but I think, the VA has a population of clinicians who could have worked and actually are on staff at a place like UCSF or other affiliated universities. But I think these people select because they have another reward system in mind. I mean, I think one of the huge fallacies in medicine, and this is invading the VA because of the neoliberal attacks on the VA, but there's this idea in our culture that the only reward that people value is money. And, there are a lot of people who actually will be content to go into medicine or healthcare to make a living and not a killing.
Well, the jobs at the VA, I mean, just at my own institution at UCSF also staffs our local VA. A lot of people coming out of residency choose to work at the VA, and there's a number of reasons why they choose to work at the VA. It's the delivery of healthcare is not overwhelmed with them. They have an interdisciplinary team doing the work with them. They're not absolutely overwhelmed by having a patient panel size that they can't handle. The patients have access to care there. I know there's been a lot of press about problems with access. The problems with access are in the private sector. I mean, there are problems with access in certain VAs, but they're way less bad than outside the VA. And so if you see a patient in the VA, you can say, hey, come back in 2 weeks. I'm a little worried about what I'm finding here. Why don't we see you again? Or, hey, I couldn't get through everything. Come back. Or they have other people on their team to work with. I mean, I just had there was a very competitive recruitment for this young woman researcher who everybody wanted in their institution, and the VA got her. And the deciding factor was the VA also does a lot of research, and they do really, really good quality research. And at the VA internally, they have grants that fund the research that the people actually think they want to do and is important. So they don't have to be on a hamster wheel of trying to find research grants just to get money. They're getting research grants for things that are really actionable, important things to research. And that's an internal grant system they have within the VA. And so she went there because it's just all in all a better job. It does not pay a salary that's more than the salary that they're offering in the UCSF Health General Clinic that can't hire anybody right now, practically. But it has, the salaries are all relatively adequate. They're just much lower than in other subspecialties, but they're adequate enough if you have a job that is doable, meaningful, enjoyable, sustainable for you as a provider. And,
Right.
that's what you're saying, stuff. It's not that there's not a salary problem in primary care, but the salary problem isn't the source of the disintegration of primary care and the reason why people don't want to go into it.
Right.
It's the experience of delivering primary care in a broken system that is the determining factor of why primary care is struggling. More people are retiring. It's only getting worse. More people, when there fewer people are going into it that are retiring. So it's really, there's a crisis in especially adult primary care where access is going to become increasingly difficult and the quality of care you receive is going to become increasingly poor. And that is a really big problem for people who have stigmatized illnesses or who are low income or have suffered from these health disparities, because those problems will be very hard to navigate for those individuals.
Well, and I think also, as you mentioned, I mean, the VA has these systems in which providers and others can work that are protective to them as clinicians. And I mean, for example, primary care in the VA is delivered in teams, and they have social workers, they have clerks, they have NPs, they have LVNs, they have RNs, they have residents. Primary care clinics have pharmacists where the patient can meet for 45 minutes with a pharmacist to find out how they can take their meds. And they have, dietitians. They pioneered this model of integration of mental health and primary care. So, you talk about the protective factors in a regular primary care clinic. You have to refer the patient to a mental health professional, and then that person may or may not make the appointment and may or may not go to the appointment. In the VA, they pioneered an integration of primary care and mental health care. So if a patient comes in and you as a primary care provider suspect that they're having a mental health or behavioral health issue, you can walk that person down in a warm handoff to a psych nurse practitioner, or psychologist right in the clinic, and they can begin the treatment right then and there. I mean, I remember a very good friend of mine who was morbidly obese, and a dear friend of mine was her primary care provider. She desperately needed to see, a nutritionist or dietitian, but, there was no one in the referral network. I mean, she needed to be given a warm handoff in that, my friend's primary care office, to that, person who would help her with her diet. And that never happened. And, about a year later, this very dear friend of mine died unloading a bag of horrendously obesogenic groceries. She just dropped dead in her kitchen, unloading her groceries. Now, I mean, obviously there's no guarantee that she would have followed the recommendations of whoever she talked to, but she would have had a better chance. And, I mean, I've watched, veterans particularly many people are averse to getting mental health help, right? No matter whether they're veterans. Veterans have it, I think, really particularly intensely because they come from a military environment where you're, taught to suck it up and particularly to deny any mental health problem. And so having these warm handoffs where you can get care. But I also think that, one of the things that we've talked about a lot is the protective factor of community and stable relationships. And the VA in and of itself is what I call a community of care. I mean, you walk into a cafeteria of most hospitals, and you'll see, residents or nurses or something talking to each other, but the patients don't necessarily talk to each other. You know, in the VA, people are talking to each other in waiting rooms, and they're talking to each other in the canteen, which has, by the way, the worst food of any hospital system I've ever been in, but that's okay. That's the only bad thing I can say about the VA is the horrible food they have. But you know, people talk to each other. I mean, I once had an experience in the San Francisco VA healthcare system that illustrates this, I think, sense of community. I was working on wounds of war, and I was sitting at a table at lunch, waiting to go interview a psychologist. And this vet comes and sits down, and we start to chat, and he asks me why I'm there, and I say I'm writing this book about the VA, and he says, "Oh my God, I have to tell you about this. You have to go talk to this guy," who was in fact the guy I had an interview with in, you know, half an hour. And I have to tell you, you know, he helped me so much with my mental health problems. He starts describing his mental health problems. I didn't ask him, you know, about his mental health problems. And I go, okay, you know, I take out my notebook. And then some guy sitting next to us is listening in, and he says, "Oh, you have to talk to me. I have to tell you." And he starts telling me about his PTSD and how they helped him with, you know, intimate partner violence. And then some other guy walks by. I mean, you couldn't make this up, you know, and gives me on a napkin his phone number and says, "You have to talk to me." And you see this, you know, that there's this community. I mean, they have veterans, they have a very big peer support. Talk about no social workers. I mean, they have many social workers. They employ anthropologists, you know, to study trauma and the cultural conditions that cause these problems that veterans have. But they have peer support groups, you know, and I've been to multiple groups where these patients come, Vietnam vets, Iraq vets, other vets come, and they sit with 25 other, you know, former service members who they talk with about their problems. And they've all said to me, you know, this is my family now, you know, and many of them, because of the trauma they experienced earlier in life and then in the military, they have no families. They have divorces and discarded relationships. You know, they have just piles of discarded relationships. And the VA provides relationships. And also, and I think we could kind of end on this, I think the VA creates a community of care for the people who work in the VA as well as for their patients. You know, I mean, people support each other, people communicate with each other, people have meaningful huddles, meaningful teams. It's not just a check the box exercise. And, you know, I think we have to protect and educate people about the importance of this system and how it can serve as a model of care. And I really want to end on those of us who are listening to this really need to not only understand how the VA can serve as a model of trauma-informed care that can serve to be a protective factor and reduce healthcare disparities, but also how the VA is being attacked now. And this incredible national jewel that we've built, people, you know, the ideologues that don't want us to have, and the money and the greed hogs that don't want us to have a decent healthcare system because it isn't profitable in their view. They are attacking the VA. And so we need not only to educate people about it as a model for reducing healthcare disparities, but also to protect it so that it can continue, expand, and serve as that model in the future. And Eddie, do you want to make any final comments?
I mean, the VA is a better healthcare system, and it's a better healthcare system for all of the reasons you describe. And it's a better healthcare system clearly documented in research by all of the metrics that we look at for care outcomes and preventative care. And a lot of the reasons have to do with what you're describing about reducing social isolation, having people who have complex health and social conditions feel welcomed there, loved there, liked there, treated with respect there, and given the care that they need and deserve to be healthy. And the VA does that, does it so well. And the more evidence we have of that working in the way it does, the more institutions like mine and most of the other institutions throughout the country look like negligent, profiteering bad guys. And I think the people who profit in healthcare are really worried about that and don't want a system that works this way and this well for these people. Or God forbid, every other system would be expected to take that level of quality care and holistic care and be a protective factor for this population. So I think the VA is an incredibly important beacon within our healthcare system that reminds us what good care looks like. And we need to protect it.
Thank you. Thank you. So thank you so much for coming to our session. And you can reach us all, either of us, through the groups that we work with. And thank you for coming. Take care.